Good evening to everybody. On behalf of IAP-TNSC, I welcome today's postgraduate case presentation. First, I will start with the pediatrician prayer by our Dr. Gopal Subramaniam, Treasurer, IAP-TNSC.
Thank you, sir. Good evening, one and all. We'll start today's program with the pediatrician's prayer. குழந்தை மருத்துவனை நிறைந்தல் எங்களுக்கு முழுமையான குணமளிக்கும் திறனை தாரும் நோயிரின் துன்பத்திற்கும் திறன் நமக்கு வழங்கப்பட்டது எப்படிப்பட்ட சிறப்புரிமை என்பதை பணிவிடம் நாம் உணர்வோமாக. எல்லா குழந்தைகளுக்கும் அவர்களின் குடும்பத்தினருக்கும் அவர்களின் சமுதாய படிநிலை மற்றும் சாதி மத பிரிவுகளை பாராமல் நலம், கற்றல், ஈகை, அன்பு, அமைதி ஆகியவற்றின் தூதுகளாக என்றும் விருப்பமாக. நம்மால் முடிந்தவற்றை மாற்றவும் நல்லவற்றை உள்வாங்கவும் மாற்ற முடியாத காரணத்துடன் ஏற்றுக்கொள்ளவும் போதுமான மெய்யறிவும் புரிதலும் எங்களுக்கு வழங்குக. உங்களது வாழ்த்துக்களையும் அருளையும் கருணையும் எல்லா சூழல்களிலும் நேரங்களிலும் அனைத்தும் கொடுத்து அருளுங்க.
Thank you, Dr. Gopal. Now I welcome our President, Dynamic President, Dr. Ismail sir, to deliver a presidential address.
Yeah, thank you, Rajendran, Gopal, and all the IAP functionaries, and of course, the respected judges, Dr. Srinivasan sir, Dr. Balashankar, Dr. Janani Shankar, and of course, the chief moderator of the day today in the postgraduate teaching, Luke Ravichalaya sir, and of course, the moderators, Dr. Senthil Kumar sir and Dr. Lakshmi Narayana sir. On behalf of IAP-TNSC, we welcome you for the postgraduate teaching. And of course, we are happy that in spite of COVID, we are able to do a good job. And of course, the students are really benefited getting exposed to different kinds of scenarios and different kinds of teachings, and especially young brains. A lot of people are coming into teaching, and we are happy that we are exposing the students to you all people, and the students are really benefited out of it. So with these few words, I wish all students are happy learning, especially the KB students who are going to present today. Thank you.
Teachers are benefited.
Yes, sir. Yes, sir.
Thank you, sir. Thank you, sir. Now it's my duty to welcome our chairperson, Dr. Luke Ravichalaya sir, and he's a renowned teacher, and he's done a lot of work during COVID time at Institute of Child Health. Currently, he's a professor of pediatrics, Madras Medical College in Chennai. I welcome Dr. Luke Ravi sir. I welcome today's moderators, Dr. Lakshmi Narayanan, and he's currently a senior consultant pediatric neurologist and Global Health City, Chennai. I welcome Dr. Lakshmi Narayanan sir. I welcome Dr. C.S. Senthil Kumar, Associate Professor of Pediatrics, KPV, Government Medical College at Trichy. And I welcome all the judges, Dr. Balashankar, Dr. Elicit Madam from ICH Chennai, and Dr. Janani Shankar, and Dr. PRC sir, and Dr. Srinivasan sir from Pondicherry. And I welcome all the postgraduates from the KPV Government Medical College, Dr. S. Piso and Dhanam, and Dr. Gautam Bharati for this case presentation. And now it is over to Dr. Luke Ravichalaya sir. Unmute, sir. Unmute.
Good evening, sir. Dr. Rajendran, sir. Good evening, sir. Sir, yes, sir. My pronouns to Dr. Srinivasan, sir. First from Jitmar Pondicherry. I always call him as Jitmar Srinivasan, sir. Only, always. And hearty congrats to dynamic team of IAP-TNSC now with Dr. Ismail, sir, Dr. Rajendran, sir, and my dear friend Gopal. They're doing a very wonderful job during this COVID time, and IAP-TNSC has led the whole national IAP itself. We have led to the top of the teaching session. So we've been doing a wonderful job, and let's continue to do the same one week for the benefit of PGs. So I won't take much of the time. So I wish all the best to all the team and all the postgraduates, sir. Thank you, sir.
Raj sir, unmute. Unmute, sir.
Dr. Lakshmi Narayanan sir, unmute.
Very good evening, everyone. First of all, I would like to thank all the office bearers of TNSC IAP chapter, including Honorable President Ismail sir and Honorable Secretary Dr. Rajendran sir. So without much ado, we will go into the session. So there's going to be a case presentation by KAP Medical College Hospital from Trichy. So we'll go through the cases as we would do for a major case in MD Pediatrics examination. So please, over to the students. Kishore?
Kishore, please, sir. Dr. Senilma, sir, please.
Good evening, sir. On behalf of the Department of Pediatrics, Trichy Medical College, we are very much thankful for giving me this opportunity, sir. Particularly Dr. Rajendran, sir, and the whole office behalf of IAP TNSC. We are very much thankful, sir. We can
Kishore, start slide, sir.
Yes, sir. Thank you.
Relax பண்ணுப்பா tense இருக்கிற மாதிரி தெரியுது. I'm making you tense. Now that smile makes you relaxed.
A very good evening to all judges and chairperson, moderator of IAP session. First of all, I would like to thank my Department of Pediatrics for giving these opportunities, and I would like to thank my chief sir, Sendil sir. And I will also like to thank IAP TNMC for giving me this opportunity to present this case. Thank you, sir. Miss A, 7-year-old female child, firstborn of non-consanguineous marriage, brought by her mother, whose reliability is good, hailing from Perambalur, came to our hospital with the chief complaint of fever for 1 week, loose stools for 3 days, weakness of both lower limb for 3 days. History of presenting illness, child was apparently normal before
Kishore,
1 week. Sir?
Hold on for a second, go back to this slide. Yeah, with
Sir.
this symptom analysis alone, would
Yes,
you think of few things before going into the history of present illness? Because the presenting complaints are the single most important aspects of the any history. So
Yes,
with presenting complaints, we will be having some clues about what are we dealing with.
Yes, sir.
Do you have anything in your mind?
Yes, sir. Sir, this case, this child presented
Here,
with
single
fever.
most important symptom is the weakness of both lower limbs, isn't it?
Yes, yes, sir. The weakness is associated with the fever, sir. So I would like to consider polioviral infection or non-polio enteroviral infection, or it can be due to a transverse myelitis, or it can be due to polymyositis or dermatomyositis or epidural abscess, sir. Since the child presented with the fever and weakness, sir, in this case.
So usually in polio, what will be the onset of weakness when compared to that of the fever?
So usually in polio, after a prodromal phase of fever, myalgia and loose stools, the fever settles and the fever again reappear as a biphasic pattern, and then child develop weakness, sir.
So what happens in Guillain-Barre syndrome? Is there any correlation between the fever and that of the onset of weakness?
Sir, usually Guillain-Barre syndrome is usually not associated with fever at the onset, sir. It may be associated with the fever 2 to 3 weeks prior to onset of weakness, sir.
That's it.
Yes, sir. Fever for 1 week, which is a high-grade fever, continuous fever, not associated with the chills and rigor. The fever relieved by oral medication, or during the interfebrile period, the child was active. The child was given oral medication for 3 to 4 times a day to subside the fever. The fever was associated with the loose stools for 3 days. The loose stools started with the onset of fever. The child had 6 to 7 episodes per day. So watery in consistency, small in volume, not associated with the blood and mucus. The loose stool lasted for 3 days. After that, the loose stool settled. Weakness of both lower limb for 3 days. Child developed weakness on the 4th day of illness. During that day, the child had fever, but the loose stool settled. The weakness was acute in onset. Initially, the child has a recurrent fall while playing with her friends around 9 a.m. in the morning. Later in the night, around 8 p.m., the child is not able to move her lower limbs. Then child called her mother. The child was able to sit up without any difficulty. Then mother made the child to stand. She was not able to stand, not able to walk, not able to climb up and down the stairs, not able to get up from sitting position, not able to hold and wear the chappals.
So in this, there is a history of fall. Either the trauma produces that weakness or it may be a coincidental thing.
Sir, it may be coincidental finding, sir. The child Sir, in this case, the trauma is coincidental, sir, because the child developed recurrent fall while playing with her friends, sir, around 9 a.m. in the morning. Then the weakness gradually progressed to involve the proximal and distal muscles, sir. So I would like to consider trauma as a recurrent fall as a coincidental finding, sir.
So rather than coincidental, can it be the recurrent fall is the earliest indication of the weakness developing? Would you like to think that way?
Yes, sir.
So that may be the earliest indication
Yes.
that there is something wrong in her legs. So that may be the mild symptom of weakness developing initially. Then it progressed to a complete weakness of both legs, right?
Yes,
over
sir.
a few hours.
Yes, sir.
So you said it is acute onset. So there are within acute onset, there are 2-3 different types that you can think of. Like there is something called sudden instantaneous onset. The another one is acute onset. So how do you differentiate between the two, and what is the importance of this sudden instantaneous onset and acute onset of paraparesis?
Sir, acute onset usually will take few hours to day to develop the weakness, sir. And acute transverse
So
myelitis.
there are two things. One is the onset, the other one is the progression. You are talking about the progression. So progression takes few minutes, few hours, few days, few weeks, or longer than that. So that is the progression. Onset is how was the symptom noticed? All of a sudden within seconds, or it was gradually realized. Like parents didn't even realize when it started. Like they would say, we don't know when it started. Possibly it would have been in the last 1 week. So that is the gradual onset, right? If it is suddenly this second he was completely fine, the next second fell down, could not move any of the leg. So that is the instantaneous onset.
Yes, sir.
Okay. So the onset and progression are slightly two different things. So we should not confuse between the two. So the onset is instantaneous, means if it is within few seconds from complete normal to completely paralysis, or if it is child was fine, but within few minutes, gradually it was noticed. Here, initially he was recurrent falling down in the morning. Then he was found to have weakness of the legs, right?
Yes, sir.
So what is the importance of instantaneous onset?
Sir, here the sudden onset is seen in case of extradural spinal cord compression, sir. A trauma, or it can be a vascular thrombosis can cause sudden onset of weakness, sir. Whereas in case of transverse myelitis and Guillain-Barre syndrome, the onset will be acute in onset, sir.
Yeah, so that's right. That's right. You're absolutely fine. So the instantaneous onset, the first and foremost is the vascular insult. Like in case of spinal, it is a spinal anterior spinal artery thrombosis, infarct, or there is a sudden large bleed. So any vascular event. Vascular event can be thrombosis or a big bleed. Okay. So sudden instantaneous onset, we would always think of a stroke. The stroke can happen in the brain level, or it can happen at a spinal cord level. So that is the importance of differentiating between instantaneous sudden onset from acute onset. All the other disorders like you enumerated, GBS, other causes of paraparesis would be infectious, para-infectious, all those will be acute onset rather than sudden onset.
Is there any terminology called subacute?
Sir, subacute, if the onset is more than 4 to 8 weeks, is subacute onset, sir. Gradually notice the weakness over a period of 4 to 8 weeks, then it is called subacute, sir.
So in terms of the like acute paraparesis, what we are talking about, subacute is between acute and the chronic. If there is a mass lesion developing, like common examples of pot spine or cold abscess developing, so those are the kind of cases you will have a subacute onset of weakness developing over few days to few weeks.
Yes.
Proceed, please.
Yes, sir. But she was able to roll over in bed, able to hold the neck, able to hold the breath. Child able to lift her hands above her shoulder and comb her hair. The child able to mix her food and feed herself. Weakness progressed over a period of 12 hours to involve both lower limbs. There is flaccidity of both lower limb present. Then the child was taken to a nearby GH. Then there the child was noticed to have both lower limb weakness and urinary retention. There is no involvement of neck and trunk and respiratory muscle. Bladder catheterization was done and the child was referred to our hospital for further management.
So what do you make of these two most important history that we have got? One is the progression completed in 12 hours. The second is the urinary retention. These are the two hard, most important symptoms that we need to analyze here.
Yes, sir. This child developed, the progression is few hours to days, sir. And there is a urinary retention and bladder
No,
involvement.
the progression is 12 hours.
Yes, sir.
The
12
progression
hours.
is 12 hours.
Yes, sir.
So that includes many disorders, that excludes many disorders. So what are the things that you will consider in this acute onset 12-hour progression? What are the disorders that you will exclude based on this 12-hour progression?
Sir, it can be a Guillain-Barre syndrome and acute transverse myelitis, sir. And these two I would like to consider first, sir, in this case.
Yeah, Guillain-Barre syndrome, not the first and foremost here, because usual cases of Guillain-Barre syndrome, usual progression is not 12 hours.
Yes.
There are cases of rapid onset, rapid progress to the nadir Guillain-Barre syndrome, that is exception. The rule in Guillain-Barre syndrome is the progression over few days to few weeks. That is the usual Guillain-Barre syndrome. Definitely few days. Okay. So that is the rule in Guillain-Barre syndrome. So 12-hour progression, we wouldn't think of Guillain-Barre syndrome as the first possibility.
Yes, sir.
Even though I'm not excluding Guillain-Barre syndrome here based on that. So 12 hours progression is more acute than usual typical cases of Guillain-Barre syndrome. And transverse myelitis, again, it can be few hours to few days. So that is definitely a possibility here. And even in transverse myelitis, the cases that progress within 24 hours to the nadir is the one that progresses within 24 hours to the nadir is the severe cases, and they are also a bit of exception rather than the rule. Usually it takes few days even in the acute transverse myelitis for the nadir to be achieved. And what do you make of urinary retention? So you said two most important differential diagnosis here, Guillain-Barre syndrome and acute transverse myelitis. Any other syndromes that you will consider at this point?
Sir, there is a early involvement of bladder is present, sir. So it may be due to acute transverse myelitis, sir. Guillain-Barre syndrome, only a few cases only will present with bladder involvement, sir.
So transient urinary retention can be seen in Guillain-Barre syndrome also. So at this point, we cannot exclude Guillain-Barre syndrome based on the urinary retention history alone, because many cases of Guillain-Barre syndrome can have a transient. So later on, when we go into the course of the disease, whether this retention is transitory, temporary, or more than 24 hours lasted longer, then only we'll be able to differentiate between Guillain-Barre and transverse myelitis based on this history. So urinary retention is one of the most important symptom, and usually it points to spinal cord as the level of the lesion. Usually in can you have paraparesis in acute CNS lesion, like above spinal cord lesion?
Yes, sir. Can also be present, like
At what level? At what level?
parasagittal meningiomas or anterior choroidal artery anterior cerebral artery thrombosis and pad thrombosis or superior sagittal sinus thrombosis.
Okay. So when you are asked such a question, first the level of the lesion, right? It's a parasagittal infarct, acute infarct can cause. Don't go into more specific diagnosis of meningioma. Meningioma is very, very, very uncommon in young children. As well as meningioma will not present so acutely in any case, and unless otherwise there is a big bleed into a large meningioma. So don't mention such a specific diagnosis which doesn't occur in pediatric age group that commonly at all. Fine. Apart from that, the other two, acute ACA infarct anterior cerebral artery infarct. Yes, even though that is a rare syndrome, that can happen, especially ICA thrombosis, that can happen, and venous sinus thrombosis causing bilateral infarct parasagittal, that also can happen. So how do you differentiate between the CNS brain involvement causing bilateral lower limb weakness acutely and the spinal level? How do you differentiate these two, brain level and spinal level?
Sir, in brain level lesion, there may be associated seizure, headache, or loss of consciousness, and there will be early bladder involvement may be present, sir. Sensory involvement may be mild, sir, in brain if it is involved, sir.
Yeah, that's right. So you will have other associated symptoms of brain involvement that you are not seeing here. As you rightly pointed out, there are no seizures, no altered sensorium, no other symptoms that will point to the brain. So that is definitely there. Sensory, you usually won't have a sensory, even if you have a sensory problem in the CNS lesion, brain lesion level, you will have a cortical sensory loss. That is a different entity altogether, rather than the kind of sensory symptoms that we would expect for a spinal cord involvement. What is the classical sensory symptom that you would expect for spinal cord syndrome?
Sir, dissociative anesthesia, sir.
What do you mean by that?
Pain and temperature will be lost, sir. Vibration and joint sensation will be intact, sir.
Yeah, that's right. At what level? Like, what is the level of the sensory involvement?
Lumbar levels.
Okay, any level it can be, but it's classically called as sensory level. So there will be a horizontal level at a dermatomal point. It can be in the cervical, it can be in the thoracic, it can be in the lumbar or lower down, but you will have a clear-cut horizontal level above which all the sensations are normal, below which the sensations are hyposthesia, and then there will be anesthesia. There will be 3 layers, right? Normal, hyposthesia, anesthesia. So that is what is classically described as sensory level, horizontal dermatomal level. So that is a classical finding for a spinal cord lesion that you will not see in a brain lesion or brainstem lesion. So that is one way to differentiate between a higher level lesion in the brain or brainstem causing paraparesis to a spinal level lesion causing paraparesis.
Okay, sir.
Clinically, how will you differentiate the weakness due to pyramidal tract lesion and that of the lower motor type?
Sir,
at the onset.
Pyramidal tract usually involve distal muscles, sir, first, and it will be movement is more affected, sir, and the weakness is usually partial at the onset, sir, and tone will be hypertonia, sir. Whereas in low motor neuron lesion, muscle, if it is lesion is in the muscle, the proximal muscle will be affected, sir. It may be episodic or progressive. If it is from nerve level, the distal muscles are affected, sir, first. In extrapyramidal lesion, both agonist and antagonist muscles are involved. So the power will be normal, sir, but there will be associated weakness may be present, sir.
What happens in spinal shock?
Sir, in spinal shock, human lesion will have signs of element lesions, sir, like hypotonia and areflexia, and plantar response will be mute, sir. Spinal shock, sir.
How long it will be there, spinal shock?
Usually lasts for 2 to 4 weeks, sir.
So if you have a spinal shock, what does it indicate? And what is the mechanism for the spinal shock?
Sir, loss of sympathetic tone, sir. There will be unopposed action of parasympathetic nervous system activity will be more, sir, in spinal shock.
Okay, it's not exactly sympathetic and parasympathetic. Basically, there is a sudden deafferentation. There is a sudden pyramidal tract and extrapyramidal tract together are involved suddenly. Then you will have a till the time the spasticity or hypertonia sets in, you will have an initial acute central hypotonia, because there is a sudden cutoff of both pyramidal as well as extrapyramidal tract afferents, right? So you need pyramidal as well as extrapyramidal tracts to maintain your tone of the muscles. If you cut off both suddenly, then there will be a central hypotonia. That is what is called spinal shock. And what does it indicate? If there is a spinal cord, there are two patients. One acute paraparesis without spinal shock, the another one acute paraparesis with the spinal shock. What is the difference?
Spinal shock may be seen in acute transverse myelitis or any vascular thrombosis causing lesion in the spinal cord, sir.
It's not about the etiology or the level of lesion. Basically, if there is a spinal shock, there are 2-3 things that are clear. One, that is, it is a very acute kind of disruption of both the pyramidal and extrapyramidal tracts. So usually it will be like hemicord or hollow cord disruption. That's when you will have a disruption of both pyramidal as well as extrapyramidal. In gradually progressive or insidious onsets like extra dural mass lesion compressing, you won't get a spinal shock, because it is a gradual onset, and by the time it takes many days and weeks, by the time it adapts to the system, so it is acute cutoff that causes spinal shock. So second one is, usually it is the severe cases that you will have a spinal shock. So the moment you have a spinal shock, that itself is one of the bad prognostic sign, especially if the spinal shock is prolonged. If it is 1 or 2 days, the spinal shock phase is gone and the hypertonia spasticity sets in, that is one of the good prognostic indicator. If the spinal shock lasts for 2 or 4 weeks, as you said, usually it can last to for 4 to 8 weeks also in some cases. Those are the cases that is severe and they are bad prognostic sign. Please proceed.
Yes, sir. The child able to recognize their father, able to tell whether it is day or night, child interested in surrounding, able to eat, there is no abnormal behavior. There is no loss of smell, blurring of vision, there is no double vision, drooping of eyelid, abnormal eye position, child able to chew the food and eat, there is no drooling of saliva while drinking water, no history of deviation of angle of mouth, child able to close eyes while sleeping, no history of ringing sensation in the ear, no history of hard of hearing.
What is the importance of visual symptoms in this case?
Sir, in neuromyelitis optica spectrum of disorder, there will be optic neuritis may be present, sir. So I would like to assess vision in this case, sir.
Okay. Yeah, that's fine. That's right. But first, when you start such question and answering such question, better to be little bit broad rather than bringing in neuromyelitis optica. So it would be better if you say in acute demyelinating cause of transverse myelitis, usually the other neural axis are associated. Usually there will be features of cortical involvement, and there will be involvement of optic nerves as well. So those are the cases. There will be acute visual loss or acute blurring of vision and very poor visual acuity. So better to be a little bit broad. Acute demyelination, that is one of the very important differential diagnosis that we will keep. And what is the importance of abnormal behavior?
Sir, I would like to assess the cortical involvement, sir, to look for abnormal behavior. Can be rarely it can be seen in ADM and porphyria type of weakness. There will be abnormal behavior, sir. And as a part of cortex assessment, I asked cortical involvement.
Yeah, that's right. So in any case of acute paraparesis or acute spinal cord syndrome, you have to assess other levels of neural axis. Neural axis meaning from the cortical level to the corticospinal tract to the brainstem, cerebellum. The cortical level includes the optic nerves also. Cerebellum, then the spinal cord. In that spinal cord, you have a cervical, thoracic, lumbar, and lower down. And then you have a neural axis that traces up to the muscle neuromuscular junction also. So all the levels of neural axis you have to elicit history, because acute spinal cord involvement can be associated with other lesions or other affection in the other levels of neural axis. So typical polysymptomatic. What do you mean by polysymptomatic?
Sir,
So
more than one.
the neural acute presentations like this can be monosymptomatic, polysymptomatic. Okay, monosymptomatic is what we are dealing with now till the way you are presenting. It's only presenting with leg involvement, weakness, paraparesis, nothing else in any other levels of neural axis. Okay, polysymptomatic means where do you see polysymptomatic? Which
Sir, in acute disseminated encephalomyelitis, there will be polysymptomatic involvement can be present, sir. And
yeah. So basically, polysymptomatic means there will be a lesion in the optic nerve, so causing visual blurring and visual poor acuity, and there will be some affection of cortex, including causing altered sensorium, behavior abnormalities, altered sleep, and seizures, and there will be some eye signs that that indicates the level of lesion in the brainstem. So at the same time, you can have a lesion in the cortex, optic nerve, brainstem, and the spinal cord. That is polysymptomatic. And that polysymptomatic is one of the characteristic presentation of ADEM. Right. So what is the importance of the deviation of angle of mouth? In what are the diseases you can have facial nerve involvement in this case scenario?
in Guillain-Barre syndrome, facial nerves commonly involved, sir. So I asked any history of facial deviation of angle of mouth in this case, sir.
Any other etiology? Yeah, Guillain-Barre syndrome, of course, yes. Any other etiology? Adam can involve.
Adam can involve, sir. Polio bulbar type of polio can also, bulbospinal type can also have cranial nerve involvement, sir.
Neuro infections that can involve simultaneously lower cranial nerves as well as spinal cord. Any other infections that can simultaneously involve both levels? So there are many atypical infections that can involve all the lower cranial nerves. That's why you are asked all the cranial nerve history. Though these atypical infections are fortunately rare, like this can be even in cases of leptospira or Weil's disease. There are other atypical neuro infections that can affect lower cranial nerves predominantly with preponderance for the lower four cranial nerves, including bulbar palsy, pseudobulbar palsy, and the facial nerves, as well as there can be simultaneous myelitis as well. Yeah, Lyme's disease and other atypical infections. So that is why you asked for facial nerve involvement. Guillain-Barre syndrome, very typical bilateral facial nerve palsy, is one of the common lower cranial nerve involvement that is seen. Okay, proceed, please.
There is no history of nasal regurgitation of feet, no history of change in voice, no history of difficulty in turning head side to side, no history of difficulty in protruding tongue, history of blunting of sensation. The child was not able to appreciate the undergarments, no history of abnormal speech, clumsiness of movement, and head nodding.
What do you mean by clumsiness of movement?
Sir, ataxia, sir.
Okay. So already, okay, arm ataxia, fine. So you can say clumsiness of hands, hand movements, because it was a little bit unclear what you're meaning. Okay, fine. So abnormal speech, again, you can have many different levels of abnormal speech. So how do you differentiate different levels of abnormal speech?
Sir, in cortical involvement, there will be aphasia, sir. It can be a motor aphasia or a sensory, or it can be a transcortical aphasia, sir, if a cortex is involved. If it is involving the muscles of articulation, nervous involvement, 10th nerve involvement, there will be dysarthria may be present, sir, that due to peripheral articulation disorder, sir.
Yeah, that's right. So the speech problems can be due to the language problem as such, that is what is aphasia, and there can be articulation problem, that is dysarthria. Again, articulation problems can be at very different levels. There can be corticospinal tract involvement causing spastic dysarthria, then bulbar palsy, lower cranial nerve involvement causing bulbar palsy and associated dysarthria. There can be cerebellar dysarthria, and below the cranial level, there can be peripheral mechanism that is involved that is causing hypophonia and other speech abnormalities. So this need to be differentiated. That will give a very important clue to the level of neural axis that is involved. Proceed, please.
Regarding the sensory symptoms, it may be a numbness, paresthesia, or even allodynia. What is meant by allodynia?
Sir, allodynia, the patient will experience a excruciating pain to a normal stimuli, sir. It is allodynia, sir.
Regarding the pain sensation, is there any pain symptoms in this patient?
Sir, the child doesn't have any hyperesthesia, sir. Only the child had a blunting of sensation, sir. Child not able to appreciate the undergarments, sir.
Apart from the not able to feel the sensation, what are the other sensory symptoms that you will elicit in cases of paraparesis?
Is there any paresthesia, sir? Pins and drinking sensation? We have to ask, sir.
So the sensory problems can be positive sensory problem, negative
or
sensory
negative,
right?
yes, sir.
Negative sensory problem is what you are saying already, numbness or blunting of sensation, not able to appreciate. That is negative symptoms. Positive symptoms are the paresthesia, pins and needles, and allodynia also will come in the positive symptom, because the touch usually should not cause pain, but normal touch causes excruciating pain. So that is the abnormal hypersensitivity of the touch receptors.
So, what's the difference between allodynia and hyperalgesia? So both same.
Hyperalgesia, there is a exaggerated painful response to a painful stimuli. The stimuli is the painful, noxious stimuli. The patient will perceive exaggerated pain, sir. That is hyperalgesia, sir.
Okay, apart from the numbness and not able to appreciate, like would you elicit any other kind of sensations? Like previously I mentioned about cortical sensations. Cortical sensation, that is one thing that we can differentiate between a cortical as well as spinal cord lesion. Then,
is there any girdle sensation you have to ask, sir?
Yeah, that we spoke about when we spoke the level of lesion. The level of lesion and the girdle sensation go together. So what do you mean by girdle sensation?
Sir, it's a bilateral dermatomal pain, sir. The patient will experience as they are compressed by a belt around the level of lesion, sir.
Yeah, it will be like a tight band or tight towel bound across your trunk at some level. So that is the kind of sensation that they will be describing. It will be like one tight sensation in one dermatomal level at any different point, like cervical, lumbar, or thoracic, like that. What does that indicate? Like if there is a girdle sensation, let us say if there is a girdle sensation at the navel level, right? So what does it mean?
It is seen in acute transverse myelitis, sir.
And it helps in localizing the level of the lesion. If it is umbilicus level, what is the level of the lesion?
T10.
T10.
So dermatomal, we have to know the level of dermatome. Okay, so that is the importance of sensory level as well as girdle sensation. And usually those cases that causes girdle sensation are usually extra parenchymal lesions, like some infiltrative lesions in the dura and extradural and extraparenchymal lesions that causes girdle sensation much more than the parenchymal lesions, because the dural pain sensitive receptors are the one that are most important in girdle sensation. Okay, apart from the sensation like pain, what else would you ask in any cases of GBS or transverse myelitis? Any other localized pain that you will be eliciting history? Back pain, neck pain.
Zone of hyper.
Not in the level of sensory, but the associated symptoms: back pain, neck pain.
Yes, sir.
In back pain, you can have very different kinds of back pain that will again help in localizing your level of lesion as well as the kind of lesion. What is the etiology? If it is extra dural compressive lesion, it will cause a different type of nerve root compression and different kinds of pain, including pain that is radiating to the legs, depending on which level of roots that are involved. So that local back pain plus the radiating back pain, that is very important for the level of lesion that is being determined. And sometimes patient can have diffuse back pain, even in cases of GBS or in cases of transverse myelitis. What does it mean? Diffuse back pain. Have you elicited history of diffuse back pain in patients with GBS that you have already seen?
Yes,
It's very common. That is one of the reasons why patient with GBS or patient with paralysis will be very irritable. Children will be very irritable, out of proportion to their weakness. That is because of the diffuse back pain. That is an indicator of involvement of multiple sensory nerve roots. Okay, so it's a polyneuritis, polyradiculopathy. So the sensory radicals are involved. So that is involved in multiple levels in GBS. So that causes excruciating pain diffusely over the whole of the back. That causes a child to be very, very, very irritable. Usually that is the main symptoms that they will be presenting with. They are very irritable, crying, and then little bit weak in the legs. Over next few days, they will progress to have a complete weakness of legs. Proceed, please.
There is no history of flushing of skin, excessive sweating, palpitation, no history of giddiness while getting up from bed. The child not able to feel the bladder sensation, not able to void urine. Urine tube was inserted to drain the urine. History of constipation present. There is no history of pain in the back, difficulty in bending down, no history of seizure, loss of consciousness, no history of headache and myalgia.
What is the importance of constipation?
Sir, here the bladder is in order to assess the bowel involvement. I asked, sir. In this case, both bladder and bowel are involved, sir.
What does it indicate?
Sir, indicates it may be due to the level, maybe at the spinal cord level, lesion can have both bladder and bowel involvement, sir.
Okay, again, it depends like what kind of bladder involvement is there. So acute retention is there. That is definitely is a sign of spinal cord involvement. As I told you, whether it's a transient or it's a lasting for many days, that is very important here. So it's a basically involvement of autonomic nervous system, parasympathetic nervous system. That is the most important for bladder and bowel function, right? Vagus nerve and its branches. So all the parasympathetic nervous system, that is very important for bladder emptying as well as bowel function. So the autonomous nervous system also is involved at both the bladder and the bowel level. That's why you have a significant constipation. So what are the other signs of autonomic nervous system involvement that you can have in these patients apart from bladder and bowel?
Patient can have tachycardia, sir. Tachycardia, bradycardia, hypertension, hypotension, and excessive sweating can be present, sir.
Yeah. So what is the characteristic of the acute autonomic nervous system involvement? How it will be? Whether it will be persistent hypertension or something?
Sir, it will be labile hypertension, sir. Labile hypertension will be present.
Because the involvement of sympathetic and parasympathetic nervous system are different and fluctuating in these kind of cases. So there will be a very labile hypertension that these patients will have. One time it will be very high, and another time it can be in a hypotensive level also. So treating these kind of hypertension will be very difficult because it is not a standard, it is not a constant hypertension that you will be coming across. So you have to be very careful about these patients whenever you are planning to treat hypertension.
What are the different types of bladder involvement?
Sir, atonic bladder, in this atonic bladder, there will be sensory supply to the bladder is impaired. So the patient will not able to feel the bladder sensation and there will be overflow incontinence may be present, sir. In case of automatic bladder, the patient will have a reflux excessive passage of urine and the bladder capacity will be decreased, sir. both internal sphincter will be affected, sir. In case of detrusor and the sphincter dyssynergia, both signals between the detrusor and the sphincter muscle is lost, sir.
So what is the importance of a headache here? What are the other?
Headache, in order to rule out polio non-polio intraviral infection, I have asked, sir. General prodromal fever, headache, myalgia. For that, I have asked, sir.
Okay. So any other case also you can have headache, like
Is in cortical involvement, sir. Acute demyelinating encephalomyelitis can also have, sir.
yeah, ADEM is very characteristic of having headache, or any other chronic, any other acute, what we call meningomyelitis. Meningomyelitis. So they can also have headache. Again, it is all dural pain, so they can have. And GBS cases, they are notorious to have headache. And some cases of GBS, Guillain-Barre syndrome, they can have headache as well as papilledema also. Even though it is uncommon, so they can have a headache, vomiting, papilledema, all that can be confusing for polyradicular neuropathy. So that can be present in some cases of GBS also.
There is no history of girdle sensation and neck pain, no history of fever, cough and cold, fast breathing, loose stools in the past, no history of recent vaccination and IM injection, no history of throat pain and neck swelling, no history of abdominal pain and psychiatric manifestation, no history of rash and arthralgia.
Okay. So what is the importance of the prodromal infection and the recent vaccination?
Sir, in Guillain-Barre syndrome, there will be prodromal fever, cough and cold will be present, sir, as a mycoplasma infection, or loose stools will be associated with Campylobacter jejuni infections, sir, in 2 to 3 weeks prior to onset of weakness. That patient may have the symptoms, sir.
Yeah. So basically, all these cases can be post-infectious or post-vaccinal, right? Even in case of acute transverse myelitis, also it can be post-infectious, para-infectious, or post-vaccinal. Okay, so this is mainly for your etiology of whether it is a post-infectious or post-vaccinal. There are many different vaccines that can cause GBS, that can cause acute transverse myelitis. So do you know any notorious vaccines that can cause GBS?
So influenza vaccine, hepatitis B vaccine, meningococcal vaccine, MMR vaccine, and TD vaccine can also cause demyelination.
Yeah, so MMR vaccine is one of the notorious for both GBS as well as for acute transverse myelitis. Recently, the COVID vaccine, do you know any particular COVID vaccine that can cause the GBS more commonly than other vaccines?
There's a Covishield that is associated transverse myelitis very rarely.
Any vaccine can cause theoretically, but the Johnson & Johnson vaccine of COVID, so that has been found to be much more associated with Guillain-Barre syndrome than any other vaccines. That's why in between it was withdrawn.
Hello, sir.
It's not audible, sir.
Any other history? Sorry, I got disconnected in between.
Yes, sir.
So animal bite. In any case of acute flaccid paralysis, animal bite is very important.
Yes,
I understand it's not very common at all. Fortunately for our region to have post-animal bite, rabies, and all those things. But even then, classical teaching and examiners would like to have that also in the history.
Yes, sir. There is no history of prolonged fever, loss of weight, loss of appetite, easy fatigue bleed, easy bruising, bone pain, no history of trauma, snake bite, no history of pica and abdominal pain, no history of canned food ingestion and honey ingestion, no history of drug intake. Past history, there is
What
no
are
history
the
of
different drugs that can cause any neuropathy or neuritis or acute flaccid paralysis? Very important history, drug intake. What kind of drugs?
Isoniazid can cause peripheral neuritis, sir, and metronidazole, nitrofurantoin, and vincristine and cisplatin can cause drug-induced neuritis, sir.
Any other drugs? Only allopathic drugs can cause, as a public perception that only allopathic drugs cause side effects, and
Can
other
be arsenic,
symptoms.
arsenic and heavy metal in other
Mercury.
native medication.
Mercury is notorious to cause painful neuropathies, very acute. All the other causes that you mentioned, the drug intake, usually they cause dapsone, another drug. All these cause very gradual onset, subacute or chronic neuropathy, right? Acute painful neuropathies are very few. Mercury is one of the notorious. Okay, so mercury containing, there are many homeopathic preparations, many alternative drug preparations that can cause acute painful neuropathy. That is much more notorious for acute neuropathies than allopathic medications. So you should not omit the history of alternative medicines, natural naturopathy and homeopathy and all other systems of medication. That is much more important. Yeah, please.
Antenatal history, the pregnancy was booked and immunized. There is no drug and radiation exposure. Antenatal scan and blood investigations were normal. Regular iron and folic acid supplementation was taken. Quickening felt at 5th month. There is no history of gestational diabetes mellitus and hypertension. Natal and postnatal history, it is a term normal vaginal delivery. Birth weight was 2.5 kg. The baby cried at birth. There is no history of NICU admission. The child was breastfed 1 hour after the birth. Immunization history, the child was immunized up to 5 years of age in nearby PHC. Pulse polio vaccination received. There is no optional vaccine given. BCG scar present. There is no recent vaccination.
Any recent polio drops that is given in the last 1, 2, 3 months?
No, sir. The child age is 7 years, sir. Last polio, pulse polio vaccination was given 2 years back, sir.
So why is that important?
Sir, pulse to polio, to rule out polio, yes, sir.
Vaccine associated.
Yeah. So of course this child is 7-year old, but if there is a history, then you have to associate with that also. So when you ask for vaccination, you should include polio drops also, especially if it is less than 5-year-old age group.
Developmental history, developmental milestone attained appropriate for age, scholastic performance was normal. Nutritional history, it was obtained by 24 hours recall method. Pre-illness, 3 days average food intake was taken into account. Expected calorie intake was 1700 kilocalories per day. Expected protein intake was 31.5 gram per day. Observed intake was 1194 kilocalories per day. There is 30% deficit. Observed protein intake was 19.5 gram per day. This is a diet chart of this child. Family history, there is no history of similar illness in the past. This is a firstborn by non-consanguineous marriage.
Which type of paraplegia runs in families?
Sir, hereditary spastic paraplegia can runs in families, sir. It usually occurs at 3 to 16 years of age group. There will be spastic paraplegia will be present, sir. The chronic and progressive paraplegia, sir.
Any metabolic disorder that can present as hereditary spastic paralysis? Urea cycle disorder, there is one particular entity that can cause hereditary spastic paralysis. Okay, So it usually presents in an older age group. So usually if it is a urea cycle disorder, you will be expecting newborn or early infant that presents. But this particular disorder, arginase deficiency, so they can present with chronic hereditary spastic paraparesis, usually in 2 or 3 siblings affected. We have had families coming with very chronically affected with the spastic paraparesis, never diagnosed, then later on found to have a urea cycle disorder, especially arginase deficiency.
Okay, sir. Socioeconomic history. Child was from a rural background. Father is driver by occupation. The child lives in a Pakka house. 2 rooms with separate kitchen was available. LPG stove is used for cooking. Unboiled tap water is used for drinking. Separate toilet facility present. No pets, no passive smoking, no overcrowding. The child belongs to lower middle class according to modified Kupusami classification. Contact history. There is no contact tuberculosis history. The history of contact with the COVID positive patient present. The father had a mild symptomatic COVID infection 1 month back, sir. Mri, Miss
So just a second. So what are the different neurological manifestations that you can have with the COVID infection? I think it's one of the hard questions.
Yes, sir. The child can have encephalopathy, seizures, and rarely fever present as fever provoked seizure, or a child can have demyelination, and Guillain-Barre syndrome can also present, sir, and transverse myelitis can also present, sir, post-COVID.
So virtually any level of the neural axis can be affected. All the post-infectious demyelination, including optic neuritis and all ADEM, all that is described. Acute meningoencephalitis is described. More commonly, post-infectious or para-infectious Bell's palsy. That is one of the most common neurological manifestation in any age group, not only children, in any age group. Say, for example, epidemiologically, we nowadays in the last 1.5 years, we come across much more Bell's palsy cases commonly than for any other 1.5 year period. So even though not all the cases are immediately post COVID infection, it can be just a para-infectious phenomena. Bell's palsy is one of the most common neurological manifestations that you can have post COVID.
Okay, sir. Summary: Miss A, 7-year-old developmentally normal child, immunized up to 5 years of age, with complaints of fever for 1 week, loose stools for 3 days, weakness of both lower limb for 3 days. Weakness is progressive, involving both proximal and distal group of lower limb muscle, with the bladder and bowel involvement and sensory involvement. Cranial nerves are not involved. Is a case of acute facet paralysis, paraparesis, symmetrical with urinary retention and sensory level.
So this is the summary. So from this, what are the most common differential diagnosis at a history level that you will consider?
This case having a symmetrical weakness involving both proximal and distal group of muscles. So I would like to consider acute transverse myelitis and Guillain-Barre syndrome as a diagnosis, sir, as it is symmetrical and involving both proximal groups of muscles, sir.
Okay.
And the child is having a bladder involvement and sensory involvement is also present. So it shows a point more towards spinal cord level of lesion. So I would like to consider transverse myelitis also.
So acute transverse myelitis, infectious or para-infectious that you would like to consider. Any other differential diagnosis?
Sir, it can be a non-polio enteroviral infection as it is associated with the fever, loose stools, and weakness of involvement, sir. It can be there, sir. Or it can be myositis or dermatomyositis, sir. But in this case, bladder involvement is also present, sir. Can be epidural.
So any viral any viral myelitis can be there. So the direct infection, that is one of the most common viruses, the enterovirus. Any other viruses that are commonly associated with myelitis as such?
Sir, herpes virus and mumps cytomegalovirus, Epstein-Barr virus, rabies virus can involve the spinal cord, sir.
Yeah.
Affect spinal cord, sir.
Yeah. Literally many different viruses, including adeno, Coxsackie, all the herpes group of viruses. All these are known to cause isolated myelitis. Encephalomyelitis and encephalitis, literally any virus can cause. But this isolated myelitis presentation can be there in many different viruses again. So you have to keep the viral myelitis as a possibility also. You cannot just keep only transverse myelitis and Guillain-Barre syndrome as the differential diagnosis. Myositis, very unlikely. Bladder involvement and sensory involvement. So myositis is very unlikely, because in a myositis you will have a pure motor syndrome. Okay, so here sensory is involved, bladder is involved, and dermatomyositis again it's a pure motor syndrome, that is unlikely a differential diagnosis here. Very rapid onset again, dermatomyositis and myositis very unlikely. Any other differential diagnosis you like to consider?
Sir, any compressive myelopathy can also be considered, sir. Pot spine or some epidural abscess can also present, sir. But
Yeah.
it is an acute onset and there is no recent surgeries in the past. ST is not there, sir.
Yeah, they can present with acute, especially paraspinal, parapharyngeal abscess. They can present with acute paraparesis. Okay, and pot spine and cold abscess. Even though it will take few days, but again there are exceptions. There are cases that present very acutely, like it will have a threshold level. It will develop over few days, but presentation will be sudden. So those differential diagnosis should always be included in our part of the world. Parapharyngeal abscesses, paraspinal abscesses, as well as including cold abscess in case of pot spine. So very important differential diagnosis to keep in cases of any paraparesis in our country.
So, one more question in the chat box they have asked, is patchy or asymmetrical involvement typically in polio or other viral myelitis too?
Sir, patchy involvement seen in anterior onset lesions, sir. Usually polio, non-polio intraviral infection. If it is acute onset, in chronic condition like spinomuscular atrophy, there will be patchy asymmetrical involvement seen, sir. It is typical of anterior onset lesions, sir.
Yeah, very characteristically patchy involvement is seen in polio, but they can occur in other viral also, but much more prevalence wise, much more commonly seen in polio virus myelitis.
General examination, the child is conscious, cooperative to the examination. The child was examined after getting consent from the father. Child is afebrile, not tachypneic, no pallor, no icterus, no cyanosis, no clubbing, no pedal edema. There is no kyphosis, scoliosis. There is no significant lymphadenopathy. Vitals, pulse is 110 beats per minute, regular in rhythm, normal in volume, no specific character, no radiofemoral delay, no radioradial delay, felt equally in all periphery pulse. Respiratory rate 24 cycles per minute, regular in rhythm. It is abdominothoracic type of respiration. The temperature 37 degrees Celsius, BP 90/60 millimeter of mercury, measured in right upper limb, lying down position. There is no postural hypotension. Single breath count 20 seconds, SpO2 98% in room air.
So, is there any other clinical parameters that can be used for assessing the respiratory weakness in acute classic paralysis?
Sir, we have to assess the respiratory rate and use of accessory muscles and chest rise, and we have to assess change in voice and weak cough and weak cough and a single breath count and tachycardia and diaphoresis. This can be used as a clinical parameter to assess the respiratory muscle involvement, sir.
Shoulder abduction also takes if the diaphragmatic.
Yeah, so not in this case, this is a purely paraparesis, but in any cases of weakness, definitely shoulder abduction, the deltoid weakness is very much correlated with diaphragmatic paralysis. Why that is? Why deltoid and
C4
C5.
involvement.
yeah,
C5
phrenic nerve is C4. So deltoid is C4, C5, C6. So phrenic nerve is C4. So these two are very closely associated. If there is a lesion of C4, C5, again there will be a diaphragmatic involvement and respiratory distress. And another important determinant is facial palsy. If there is in a case of Guillain-Barre syndrome, if there is a bilateral facial paralysis, that patient has a high likelihood of proceeding to have respiratory muscle paralysis, mostly ending up requiring assisted ventilation. So that is another determinant. What is the importance of single breath count? 20, what does it mean?
Sir, in order to assess the respiratory muscle involvement, it is used, sir. But in pediatric age group, it is not much validated, sir. But it can be used first as a baseline, and we can compare, sir. Is there any further deterioration in single breath count is there in order to look for respiratory muscle involvement, sir?
So for a given child, it is the trend that is most important than a single count, right? So 20 doesn't mean anything to me, right? So it is a trend, as you rightly pointed out. It's a baseline that is 20. If after 6 hours, after 4 hours, after 2 hours, if the child has the single breath count of 12 or 14, that definitely means he has deteriorated from the baseline 20. So it's a trend that we need to follow, and be a little bit cautious when you present such finding. 20 is a little bit on the higher side. For a child of 7 years, 20 is a little bit higher side. Usually we have the counts between 14 and 16. That's how it is usually. So be sure twice before you present this finding of 20.
Okay, sir. Anthropometry, the weight of the child is 15 kg of expected of 22 kg, which falls under 3rd to 10th centile. Height is 110 centimeter of expected of 119 centimeter, which falls under 3 to 10th centile. BMI is 13.6, which falls under 10 to 25th centile. So growth chart, IAP growth chart is used, and corresponding values are plotted for this side. Head to foot examination, there is no dysmorphic faces, no rash, no neurocutaneous marker, BCG scar present, skull and spine normal, no gibbous, no pes cavus, no spinal tenderness, no bony tenderness, Foley's catheter in situ.
So what are the different rashes that you can have in this syndrome? What are the different etiologies that you can determine by looking at the skin rashes?
Sir, in Lyme's disease, there will be erythema chronicum, erythema marginis chronicum can be present, sir. In dermatomyositis, there will be heliotrope rash and Gatron's papules may be present, sir.
Any other? Like what are the differential diagnosis that you mentioned?
Sir, a non-polio intraviral infection can also present with the rash, sir.
Any viral, for that matter, any viral infection that can cause viral myelitis. There are different kinds of skin rashes, exanthematous skin rashes that you can get. So not only enterovirus, not only non-polio enterovirus, all other different viruses that can cause isolated myelitis can have rashes.
Yes, sir. Higher mental function, the child is conscious, oriented to time, place, person. The child able to understand the words, repeat the words. The child is able to read and write and speak fluently. Memory, immediate, recent and long-term memory intact. Intelligence normal, behavioral normal. The child was a right-handed person.
Intelligence normal, better to avoid. Okay, so then the examiner will ask, how did you assess the intelligence? Like IQ, intelligence is not a simple measure to assess. So that is just your impression. So better to avoid intelligence normal. All other things look fine. So they may ask you what are the different ways that you assessed memory, immediate, recent and long-term memory. So you will be needing to defend that question. Intelligence normal, definitely no.
Okay, sir.
We cannot assess intelligence normal in the bedside examination.
Yes, sir.
Yeah, proceed.
Cranial nerve examination. Olfactory nerve. The child was able to perceive the chocolate smell on both nostrils. Optic nerve. Visual acuity was 6/6 on both sides. Field of vision, it is same as that of examiner. Color vision, normal. Pupillary reflex, bilateral pupil was equal 3
Why
millimeter.
color vision is important? Sorry to interrupt.
Sir, in demyelinating spectrum of disorder, the visual abnormalities will be present, sir.
So in the early cases of optic neuritis, so visual acuity may be normal, but color vision will be one that will be impaired at the earliest. So if you want to rule out early optic neuritis, color vision is the single most important test that you will do. And in this case of paralysis and myelitis, you should always look for optic nerve involvement in many different forms. One is visual acuity, second is color vision. What are the other ways to assess optic nerve function? Not only bedside plus investigative.
Sir, swinging flashlight test can be used, sir.
Yeah.
Swinging,
and another one?
Perimeters
very
for field of image.
fundus examination.
Yeah. So fundus, what will you see in optic neuritis?
Usually, fundus will be normal in optic neuritis, sir.
Initially, there will be pallor, disc pallor.
No. Disc pallor is not optic neuritis. So disc pallor is optic
Followed
atrophy.
by-
So you can have a normal fundus. That's a common finding that in optic neuritis. You can have papillitis. You can have a erythematous optic disc appearance. So it can be normal or it can be papillitis appearance, that is erythema. Rarely there can be pseudopapilledema appearance also in optic neuritis. So that is fundus examination. And swinging flashlight, what do you see?
Relative afferent pupillary defects.
Yeah, RAPD. Yeah, relative afferent pupillary defect that you can have. So there will be, instead of when you shine the torch, instead of constricting, it will dilate. Right?
Yes,
so that is the swinging flashlight. Okay. What are the other ways of assessing optic nerve involvement? Subclinical optic nerve involvement, because that is the most important. In many cases of myelitis, all these features of optic nerve can be normal. Still, there can be subclinical involvement of the optic nerve to assess whether there is a polysymptomatic involvement of neural axis in ADEM or MS or any other demyelinating cases.
Optical coherence tomography. If investigational wise, if we can do so.
Okay, that is one.
Visual evoke potential.
Yeah, that is one of the most common tests that neurologists do to look at subclinical involvement of optic nerve involvement in case of any myelitis, any acute demyelination. So visual evoked potential, VEP, that will cause prolonged conduction time in the anterior optic nerve pathway. So that is one of the most important tests, VEP. Please go on.
One question has been asked that, and how did you test the color vision?
Sir, color vision is checked by use of Ishihara chart, sir. We have to tell the child to trace the color, sir. It will be in the shape of numbers. Then we have to tell the child to trace 8, like that. We have to tell, or we can bedside. We can give the objects of different colors, and we can ask the child to identify, sir.
Usually it is a color wool that is used. No, the bedside examination, Ishihara is definitely there, but before that, in the bedside examination, it's usually color wool rather than any other different object. So you have 3 different wool patch or whatever you call it, red, blue, and green of these 3. So that you test. That is the most commonly used clinical test to describe color vision. And in optometry, they have different. They have lights, green light and red light. In optometry, they assess color vision.
Regarding the field of vision, whether perimetry test can be done for this age, 7 years old.
Above 7 years, we can do perimetry, sir. 3 to 7 years, we can assess by confrontation method. If the child is above 7 years, we can do perimetry, sir.
The age cutoff is not that very clear. Like you need a lot of cooperation from the child to perform perimetry reliably, because the child should always focus on one particular light that is shown in the perimetry. So it depends, it varies, and even many times teenagers or young adults are even not able to cooperate for that kind of testing. So the reliability or the validity of the test will be different. So you don't have to quote one particular age, but you have to discuss all these different parameters. So it depends on the child cooperativeness and the child's level of interest, child's level of attention. All those different things are there for getting a reliable perimetry.
Okay, sir. Oculomotor, trochlear, and abducens nerve. Extraocular movements, full range in all four quadrants. There is no ptosis. Trigeminal nerve, child able to perceive pain and temperature over all three divisions of the trigeminal nerve. The child able to clench the teeth. On opening of mouth, there is no deviation of angle of mouth. Corneal and conjunctival reflex present. Jaw jerk absent on both sides.
Extraocular move, just go back. Extraocular full range alone is not complete examination. See, we already discussed this can be a case of polysymptomatic edem. So in that no ptosis, full range extraocular muscle movements is not complete. You can have different 1.5 syndrome. You can have different adduction, gaze paralysis, abduction paralysis. All different kinds of brainstem involvement can be there. So definitely you have to mention there is no squint. That is single most important. And conjugate movements are normal. And gaze movements are normal. And the vertical movements are normal. Okay. So the extraocular movements, full range movements is just one aspect. The squint and the primary conjugate movements are slightly different aspects. And gaze, when you trace the finger testing that usually you do for full range of extraocular movements, that can be normal. But if you ask the patient to look at to the right, that is a gaze, right gaze, that can be impaired. Okay, so you have to specifically mention there is no squint, conjugate eye movements are normal, and the gaze eye movements are normal. There is no gaze paralysis. At least this will complete the oculomotor examination.
Facial nerve examination, motor part, wrinkling of forehead present on both sides, closure of eyelid, the child able to close the eyelid, both the eyelid, nasolabial fold present on both sides, child was able to hold the air. On saying E, there is no deviation of angle of mouth. Sensory part, taste sensation from anterior two-thirds of the tongue present on both sides. Vestibulocochlear nerve, Rene's test, air conduction is more than the bone conduction on both sides. Weber test, it is heard equally on both sides. Absolute bone conduction test, it is same as that of examiner. Glossopharyngeal nerve, palatal reflex, gag reflex present, and uvula in midline. Spinal accessory nerve, the child is able to shrug the shoulder against resistance and able to turn the neck against resistance. Hypoglossal nerve, bulk of the tongue was normal. There is no deviation of tongue while protruding. There is no fasciculations. Motor system examination, bulk, there is no difference in bulk on both upper limb and lower limb on both sides. Tone, upper limb tone was normal, and lower limb there is hypotonia was present on both sides. Power, shoulder flexion, extension, adduction, abduction was 5/5 on both sides. Elbow flexion, extension was 5/5 on both sides. Wrist palmar flexion, extension was 5/5 on both sides. Hip joint, flexion, extension, abduction, adduction was 2/5 on both sides. Knee joint, flexion, extension was 2/5 on both sides. Ankle joint, plantar flexion and dorsiflexion was 2/5 on both sides. Toe grip weak. Neck muscle, the child is able to neck the muscle and able to flex the neck against resistance. Trunk muscle, the child able to turn side to side in bed.
Okay, just go back. 2/5 in both proximal as well as distal, right?
Yes,
There is no gradient, there is no differential involvement at all, right?
Yes, sir.
So from the history of the nadir that you described, I thought it was 0/5. Is that correct? It was 0/5 at some point. You said there was no movement of the legs at all completely, no? The
Yes, sir. Yes,
nadir.
sir.
So from that point, the examination point, it is improved, is it?
Yes, sir. Child was examined after 5 days of illness.
Okay.
Reflex, bicep reflex was 2+ on both sides. Supinator reflex 2+ on both sides. Tricep reflex 2+ on both sides. Knee jerk absent. Ankle jerk absent.
So what does that mean? The knee jerk, ankle jerk absent. What does that mean?
Sir, areflexia is present in this case, sir. In lower limbs, sir, especially in lower limbs. It can be seen in Guillain-Barre syndrome or a spinal shock. The child may be in spinal shock, sir, stage of spinal shock, so the reflexes are absent, sir.
Yeah, so rather than saying it's a Guillain-Barre syndrome, better to say it's a
Developmental.
Yeah, because it's a paralysis and there is a urinary retention that is lasting for more than 24 hours, and only the legs show areflexia. In Guillain-Barre syndrome, you will, even though the power can be normal in the upper limbs, Guillain-Barre syndrome, there will be a diffuse areflexia. Even if the power of the upper limb is normal, the reflexes will be gone fast. Okay, but this kind of power normal, reflex normal, power less and reflex gone, that will be seen in transverse myelitis rather than Guillain-Barre syndrome. Do you understand what I
Yes,
mean?
sir. Yes, sir.
Even with the normal power in the upper limb, the reflexes will be gone in the Guillain-Barre syndrome.
Guillain-Barre syndrome. Okay, sir. Superficial reflex, abdominal reflex present on both sides. Plantar reflex, no response on both sides. Anal reflex absent. Gait could not be tested. Coordination.
Jaw jerk, you didn't mention jaw jerk even in the lower cranial examination also.
Sir,
okay, fine.
Yes, sir.
If you mentioned, that's okay. So
Yes,
it was normal, is it?
Jaw jerk was absent in this case, sir.
Absent. Okay. So it can be normal or exaggerated usually. So absent jaw jerk. Okay.
Coordination upper limb normal. Lower limb could not be tested. No involuntary movements. Sensory nervous system examination. Superficial sensation.
So what are the involuntary movements that you can get in paralysis? Like what are the different involuntary movements you can get? Like if it is ADAM, you can have all the different chorea, dystonia, all that different you can have. But in case of specifically paralysis, what are the different abnormal movements that you can get? Spasms, there are something called spinal spasms. So there are flexor spasms, there are extensor spasms. Flexor spasms are much more common in spinal cord lesions, especially the transverse myelitis also. Okay, so that is usually seen when the spinal shock is gone and the hypertonia spasticity is setting in. You can have flexor spasms. The muscles of the leg go into a flexion for a brief time. And it go into almost like it is like your spasm. Then it relaxes. Then it goes into a spasm and relaxes. So this is flexor spasm. Very characteristic movement in spinal cord lesions.
Okay, sir. Superficial system exam, superficial sensation, touch, pain, temperature. The child was not able to perceive below the level of L1. Deep sensation, vibration, cushion, and pressure sensation. The child was not able to perceive below the level of L1. Cortical sensation, tactile localization, intact on both sides. 2-point discrimination. The child is able to discriminate 2 points. Graphesthesia intact. Stereognosis. The child was able to identify the objects.
How do you elicit the sensory level? Like below L1, you are saying, no? How do you elicit this?
Sir, at the level of inguinal ligament, it corresponds to L1, sir. And at the level of knee, it is L3, sir. Based on the dermatomal pattern, simultaneously, we have to, on both sides, we have to compare, sir. Dermatomal wise, we have to check one by one dermatome, we have to check, sir.
Yeah, so what is the common method? How do you elicit this? Like you are correct, but basically you go below upwards. Okay, you trace the thing that you used for light touch or deep touch sensation. Many times we just roll our finger or blunt tip of your throat swab. So you roll from below upwards, both sides, from the thighs, legs, thighs, and the inguinal region and the trunk. So you trace with your finger or the tip of the throat swab. So at the point at which the sensation is different, first you have to note whether different. Then you have to elicit, come back to that level where it is different. So there will be a level where it is hypoesthesia, there will be a anesthesia below that level. So you have to trace your finger or the tip of the throat swab to elicit this sensory level.
Okay, sir. Cerebellar signs absent. There is no meningeal irritation. Spine and cranium normal.
What are the cerebellar signs you looked for?
Sir, head nodding and nystagmus and abnormal speech, sir, like
Cerebellar dysarthria, not there.
dysarthria, sir, and tandem walking, pendular knee jerk.
No. So when such a question is asked, you have to enumerate what did you look for in this patient. So tandem walking is not there in this patient. So you have to be a little bit careful in answering the question. Right. So you should not enumerate all the cerebellar signs that is given in the textbook. So what are the cerebellar signs that you were able to elicit in this patient? You should be able to tell, right?
Okay.
Yeah. So listen
Finger,
to the
nose,
question.
finger test.
Yes.
Dysdiadochokinesia.
Yes. The heel shin test, of course, you won't be able to do because it's a 2/5 power. Okay. And the gait you won't be able to assess. And the stance ataxia, again, you won't be able to assess. But the truncal ataxia, you can comment. And all the arm ataxia signs, you can. Dysmetria, post pointing, and finger nose, as you said, finger nose. All that you should be able to enumerate. Fine.
So regarding the meningeal limitation, what is meant by Lagermite sign?
On flexion or extension of neck, there will be sudden shock-like pain sensation will be spread to the trunk and the neck, sir. It is seen in multiple sclerosis and
Myasthenia gravis.
multiple sclerosis.
Not in myasthenia.
No.
So any acute demyelination you can get.
Yes, sir.
Multiple sclerosis is the classical one. Any acute demyelination you can get.
And okay. Yes.
Other system examination, cardiovascular system examination, apical impulse felt at fifth intercostal space at midclavicular line, first and second ulcer here, which is normally split, no murmur, JVP is normal, respiratory system examination, trachea in midline, bilateral air entry present, normal vesicular wetstone head, there is no use of accessory muscles, abdomen, soft, no organomegaly, bladder was distended prior to catheterization, there is no free fluid. Differential.
Which condition you get a cardiovascular involvement with the ataxia?
In Frederick ataxia, there will be cardiomyopathy may be associated, sir. Ataxia and cardiomyopathy will be seen, sir.
What other findings will be there in Frederick's ataxia?
In Frederick ataxia, there will be ataxia and the deep tendon reflex will be lost, sir. And deep tendon reflex.
What about position sense, sir? That is
preserved. The posterior column sensation will be preserved in Frederick's ataxia.
the problem. Position sense will not be there.
My differential diagnosis is my first differential diagnosis is transverse myelitis in this case, and second one followed by Guillain-Barre syndrome. As this case, there is a symmetrical non-progressive muscle weakness was present, involving both proximal and distal group of muscle. There is early and persistent bladder involvement was present, and a clear sensory level was present. So I would like to consider transverse myelitis as my first diagnosis.
So it's not non-progressive, it's acute, rapidly progressive.
Yes, sir.
Okay, symmetrical, acute, rapidly progressive paraparesis.
Okay. And the point which against my diagnosis of plantar is no response and deep tendon is absent, as this case was in spinal shock. And my second diagnosis was the Guillain-Barre syndrome, as the child is having a symmetrical and predominantly motor weakness. But the point against my diagnosis in this case was a fever, and early and persistent bladder involvement was present in this case. And the other viral infection viral infection induced myelitis also I would like to consider, sir.
So there's a question about whether it's rapidly improving also. So that you didn't mention that much in the case presentation. When I
Yes,
asked
sir.
about 2/5, then you mentioned it's 5 days after the
Yes, sir.
presentation. So could you tell us a bit about the course of the illness from the
Yes, sir.
onset to the point that you uh, examined the child, course of the illness?
Yes, sir. Yes, sir. The child developed weakness on the 4th day of fever, sir. The child came to our hospital on the after 3 days of weakness, sir. After admission, there is no further progression of weakness, sir. After starting treatment, the child showed improvement in the tone and reflex after 1 to 2 weeks, sir. But there is no further progression of weakness after 5 days of onset of the symptoms, sir. And child showed improvement after 1 week of hospital stay, sir.
Okay, so there is acute onset, rapid progression of the weakness, nadir achieved within 12 hours, as you mentioned, and there was a plateau phase for nearly 1 week. Then there was some improvement.
Yes,
correct?
sir. Yes, sir.
So, what does that mean?
Sir, this nadir correlates with demyelinating illness like transverse myelitis, sir, because the nadir is achieved very fast, around 12 hours, and there is a plateau phase of shorter duration, followed by improvement is present, sir, in this case.
So, based on that course alone, the duration of that alone, you will not be able to differentiate between transverse myelitis or Guillain-Barre syndrome because both can have similar timeline.
Yes,
so
sir.
we said there are exceptional cases of Guillain-Barre syndrome that progresses to the nadir within 24 hours. So they are there, and there can be 1 week plateau phase in many cases of Guillain-Barre syndrome, and they start improving. That is the course even in transverse myelitis, even in Guillain-Barre syndrome. So based on the timeline alone, you will not be able to differentiate between the two. Only point will be the persistent bladder involvement that goes more in favor of transverse myelitis, and the sensory level involvement. So that again goes in more favor of transverse myelitis rather than Guillain-Barre syndrome. But the timelines are similar.
Yes, sir.
And in terms of the prognosis, does it mean anything? The rapidly progressive paraparesis and the spinal shock. Does it mean anything in terms of the prognosis, the long-term
Yes, sir.
recovery? Like the parent is
Yes,
asking,
sir.
sir, how long it will take for my child to start walking? That's a common question you will get.
Yes, sir. So as this child is having a spinal shock and rapid progressive symptoms, so the prognosis is poor, sir. Usually after weeks of treatment, the child may be able to walk, but there will be residual weakness and bladder involvement may be present, sir.
Okay. So rather than saying the prognosis is poor, so because already the child started improving 2/5, 2/5 is not bad. So that's a good improvement, right? So the rapidly progressive transverse myelitis and the spinal shock, but the spinal shock improved within 5 days, 7 days. So that is another important aspect that you should keep it. Like we discussed, if the spinal shock phase lasts more than 2 to 4 weeks, that is a bad prognostic factor. The rapidly progressive paraparesis achieving nadir within 24 hours is another determinant for bad prognostic factor. Bad prognostic factor. Okay. So yeah, there will be recovery, there will be improvement both in cases of Guillain-Barre syndrome as well as transverse myelitis. But what is the level of improvement and how long it takes? These are the two most important questions. Whether there
Yes,
will
sir.
be 50% improvement, 80% improvement, 100% improvement, or over what time course? 1 month, 3 months, 6 months, 12 months. So these are the two important questions that will be asked again and again. It will not be able. You will not be able to be very categorical or very accurate in predicting these, but you will be able to say like there will be improvement over next 1 to 3 months timeline. But how much will be the improvement? There is a bad prognostic factor already present in terms of rapidly progressive paraparesis that is achieving within 24 hours. So I would keep that in mind when I say possibly it will take few months for the recovery. And the recovery may be a little bit incomplete. So these are the ways that you can discuss the prognosis.
Diagnosis: 7-year-old female child came with a history of acute onset of symmetrical weakness of lower limb, which is rapidly progressing, not involving the neck respiratory muscle, with bladder and bowel involvement, sensory level at L1, no cranial nerve involvement, with a hypotonia and areflexia in both lower limb both lower limbs. The diagnosis of a transverse myelitis.
Can you be a bit more specific in transverse myelitis? Like what kind of transverse myelitis are we discussing?
In this case, it can be a post-infectious.
There was no prodromal
Yes,
illness, right?
Yes, sir.
So acute transverse myelitis, that is clear.
Okay.
So it is called acute transverse myelitis because there are chronic forms also. So it is acute transverse myelitis. In that, there can be 3 different forms: post-infectious, post-vaccinal, or idiopathic.
Yes, sir.
In your case, there is no history of vaccine.
Yes,
There is
sir.
no history of a prodromal illness.
Yes, sir.
There was a loose stool, right? There was a
Yes,
loose
sir.
stool and fever.
Yes, sir.
So there was a prodromal illness. So it is a acute para-infectious or post-infectious transverse myelitis.
So in this case, the question has been raised, right? Respiratory muscle assessment has not been done, not assessed.
Sir, neck and trunk muscle was assessed, sir, and respiratory muscles we have assessed by respiratory rate and use of accessory muscles, and chest rate and single breath count was used to assess the respiratory muscles.
Okay, is there any term called acute flaccid myelitis? What is that?
Sir, acute flaccid myelitis can be seen in intraviral infection 68 and 71. There will be asymmetrical motor weakness will be present with no or a minimal sensory involvement, sir.
What about the prognosis? Is it,
Sir, there will be residual weakness and will be present, and prognosis poor when compared to other transverse myelitis.
I've heard of the term called paraplegia in flexion and paraplegia in extension.
Sir, paraplegia in yes, sir. Extension, it may be tone will be more, sir. There will be spasticity, and mass effect will be seen in paraplegia in extension, sir.
On mass reflex will be present in paraplegia in flexion. In extension, it will not be there. And moreover, withdrawal reflex will be present in flexion and not present in extension. Okay, proceed.
Yes, sir.
Investigation: the child having a complete blood count of total count 6,000, polymorph of 40%, lymphocyte was 47%, hemoglobin was 10.7, platelet was 1.5 lakhs with the NLR ratio of 0.85. Peripheral smear is a microcytic hyperchromic anemia with neutrophilic leukocytosis. Of RFT was normal and LFT was normal. Serum electrolytes was normal in this case. Stool sample for AFB was sent. Fundus examination was normal. Kovid RT-PCR was negative. The child having had a elevated C-reactive protein and serum ferritin is also elevated 613 nanogram per ml, and D-dimer is also elevated 1100 nanogram per liter. Covid antibody is reactive in this case.
Is there any correlation whether the criteria has been fulfilled? It's due to COVID or it's a coincidental? Because the zero prevalence is nowadays more than 60%. So it may be a coincidence also. No? How the criteria fulfills in this situation?
Sir, the child is having a fever for more than 3 days, sir, and this child is having abdominal symptoms like loose stools was present in this case, sir. And this child is having a neurological system involvement. There is both GA and neurological system involvement was present in this case, sir. In investigation wise, the coagulopathy, the D dimer was elevated in this case, and the inflammatory markers CRP was elevated, sir, and COVID antibodies also reactive, sir. But as it can be a diagnosis of exclusion, we have to rule out the other cause, and then only we can tell if this can be due to post-COVID VC presentation, sir.
Did you have the antibody characterization of IgM or IgG COVID antibodies?
No, sir. In our hospital, we are doing both IgG panel only we are doing, sir. There is no characterization done in this case, sir.
If IgM was positive, that would have been more in tune with your diagnosis of acute infection, right?
Yes, sir. MRI spine with the brain screening was done, which shows a hyperintense lesion in T2 weighted image. Involving cervical and dorsal cord with the cord enlargement is also present. There is no contrast enhancement present in this case, sir.
So go back to the MRI, please. So what is this MRI appearance is called? Like there you can see, can you point out where do you see that hyperintensity? Okay, someone else is doing, okay, yeah.
Yes, sir.
So there, higher up also in the cervical region.
Yes, sir.
Yeah. So from there you can trace from there to down. So what is this appearance called?
Sir, a longitudinal tract involved extensive myelitis is present, sir.
So this is a very characteristic appearance. One is the central cord involvement. The other one is multiple, more than 3 spinal levels involvement. Here it is from the lower spinal, lower cervical to the lumbar or even to the conus medullaris also is involved. So it is a longitudinally extensive transverse myelitis.
Yes, sir.
So that is the term MRI term used for this kind of appearance. Again, this is one of the prognostic factors for if it is completely involving the whole cord from the cervical to the conus medullaris, that is one of the bad prognostic signs. So longitudinally extensive transverse myelitis.
So usually in multiple sclerosis, how many segments will be involved?
Sir, in multiple sclerosis, less than or equal to 2 segment is involved, sir. More than or equal to 3 segments will be involved in neuromyelitis optica spectrum disorder, sir.
So the level of involvement is one. The other one is in multiple sclerosis, there will be the periphery of the cord that is involved. So here it is the central cord that is involved. So that is seen in all other myelitis except multiple sclerosis, where the periphery of the cord is involved in multiple sclerosis. In neuromyelitis optica, in transverse myelitis, in ADEM, this is the picture that you will see. So this will not differentiate between these disorders, where you will have the whole cord involved, the central cord involved, and longitudinally extensive involvement will be seen in ADEM, NMO, as well as transverse myelitis, and many other different cases of myelitis also.
So in which type of infection will get predominantly the conus and cauda in icona? Conus medullaris and cauda icona. Which type of infection?
Sir, cytomegalovirus and Epstein-Barr viral infection.
Cytomegalovirus, okay, but usually it will be seen in immunodeficiency state, not in non-conditions.
Okay, sir.
Can you have a normal MRI in these cases? Say, for example, this MRI you did and the MRI came back as normal. Will you be surprised? So in other words, the question is, can myelitis be there with the normal MRI appearance?
Yes.
So answer is yes. So there are many acute transverse myelitis cases where the MRI can be completely normal. So a normal MRI does not rule out acute transverse myelitis. Okay. The other question is, like in case of Guillain-Barre syndrome, what will you see?
Sir, there will be
in the MRI.
contrast enhancement of the nerve roots, sir, will be present, sir. Cardiac enhancement will be present, sir.
Yeah. The Guillain-Barre syndrome, one of the hard finding and one of the most important investigation is MRI with contrast, and the cranial as well as the spinal nerve root enhancement is one of the most important finding, because many times in early Guillain-Barre syndrome your CSF will be normal. It will take more than a week to show your albino-cytological dissociation. Your nerve conduction study can be completely normal within the first week of Guillain-Barre syndrome. In that scenario where your LP is normal, CSF is normal, nerve conduction study is normal, this is the only investigation that you can do that will prove that this is a GBS. So you have to do spine MRI with the contrast to see for nerve root enhancement. Go ahead.
CSF study was done.
What is the MRI appearance in enterovirus myelitis? Do you know enterovirus myelitis? What is the MRI appearance? Yeah, anterior cell
hyperintensity will be present.
Yeah, so it is called cobra head appearance. Only the anterior horn cell in both right and left side will be showing hyperintensity and enhancement. If you see in the axial, it will be 2 dots. How a cobra head, there will be 2 marking on the back. So that is called cobra head appearance of enterovirus myelitis. Only the anterior horn cell show hyperintensities.
Okay. CSF examination was done on the second week of illness. The cell was 16 cells was present. There is no polymorphs. Protein was 60 milligram per deciliter and sugar was 68 milligram per deciliter, which is normal when compared to the blood sugar level. Culture and sensitivity, there is no growth, and viral marker was sent. That was also negative in this case, sir.
So you have to be specific which viral marker. So sir, which viral PCR was done, that you have to be specific.
Okay, sir.
And please.
We have done JE virus marker we have sent, sir, and herpes simplex and enterovirus 3 PCR we have sent in our lab, sir.
Yeah, so be specific on that. Can you call this albino-cytological dissociation? Cells are 16, protein 60.
No, sir, the cell is elevated, sir. In albino cytological dissociation, the cells will be normal and the protein will be elevated, sir.
It's not cells normal all the time. So basically there will be disproportionate increase. Okay.
Yes, sir.
So cells need not be normal all the time. So there can be lymphocytic pleomorphonuclear lymphocytic pleocytosis that can be seen in the CSF. But the number of cells and the protein elevation will be out of proportion. That is what you mean by albino-cytological dissociation. It is not normal cells all the time.
Okay,
so here 16 and 60, you think it may be proportionate. It is not out of proportion. So, yeah.
We have sent for a NMO panel, sir. Aquaporin and aquaporin antibodies and MOG antibodies we have sent. It was negative in this case, sir.
So what is the importance of this test?
Sir, it tells there is an auto antibodies against aquaporin and MOG antibodies. This child may have recurrence in future. We can the child may need a disease modifying agent, sir, like azathioprine, mycophenolate mofetil, cyclophosphamide, and rituximab, and can be helpful in this case, sir.
Yeah. So nowadays it's very, very important to be sure what are we dealing with. Previously, like 10 years ago, when we were neurology residents, so we never used to do NMO and MOG antibody and all 10, 12 years ago, because that time it was considered first episode, it's okay. You wait. If there is a recurrence, you can do, right? But now it is always mandatory, even in the first episode of myelitis or first episode of demyelination for that matter, you have to definitely do NMO as well as MOG profile, so that you are sure what you are dealing with and you can prognosticate, as well as you can monitor these patients more closely.
Yes.
Anything else you can do in the CSF apart from these?
Sir, for oligoconal band we can see, sir, or IgG index can be calculated. you
So that is
suspect.
little bit non-specific. Yeah, that's correct. So it's a little bit non-specific. So if it is a positive, it will go more in terms of recurrent demyelination. Many times it can be um, multiple sclerosis, that kind of determination. Again, it is a very non-specific marker. But these antibodies are these specific markers. If it is NMO positive, then you have to closely monitor the patient and you may decide about starting some medications. So it's very, very important. So having said that, how do you monitor these patients? This is first episode of demyelination, right?
Yes,
So
sir.
how do you monitor these patients? How often would you do investigations or MRI?
Yearly once we have to assess vision and neck spasm and steroids course we have to monitor in this case.
So
6
MRI
months.
definitely after 3 to 6 months you have to do one more MRI.
Okay, sir.
3 to 6 months later, if there are completely normal, if there is another episode 1 month down the line, of course you will do an MRI. Even though if it is it can be optic neuritis, it can be any other polysymptomatic involvement. So you can do MRI if there is symptoms. If there are no symptoms, 3 to 6 months down the line, definitely you have to do MRI to see are there any new lesions, silent lesions. And after 1 year, you have to definitely do MRI, brain and spine. One more thing I just missed. Did you do MRI brain screening also in this patient? That is the single most important thing.
Yes, sir. We have done. Yes,
You
sir.
didn't
We
show
have,
that. You didn't mention that. So
the cuts is not available, sir. We have
yeah,
received, but we have done both, sir.
yeah.
Brain
What is the
screening.
importance? Why do you need MRI brain? See, we are talking about paralysis. We are talking about only leg weakness. Why MRI brain is important?
Sir, ADM can be associated. There will be demyelination in the brain, and multiple sclerosis can also allow brain lesions, sir.
Okay. Anything else? Like let us say there is no ADM findings. There are no findings to suggest MS in the brain MRI.
NMOSD.
Yeah. So what are the MRI brain findings that you will have in NMO disorders?
Optic nerve involvement.
Yeah, it may or may not be there. Anything else? So you can have
White matter.
Yeah, you can have white matter hyperintensities in the periaqueductal regions. Periaqueductal regions. That is very specific for NMO disorder. That is where your aquaporin channels are the maximum. Periaqueductal gray and the white matters.
Okay.
So you will have a bilateral symmetrical white matter hyperintensity small specks in brainstem as well as in the cerebral hemispheres also you can have. So NMO you can show a brain lesion, silent, asymptomatic brain lesion, as well as in MOG disorders you can have asymptomatic silent lesion. Usually in ADEM you will have a symptomatic lesions, right?
Okay.
Okay.
This is a child on admission after a pulse dose steroids of 30 mg per kg 5 days, followed by oral steroid. Child improved and able to walk, but child had persistent bladder involvement, which takes prolonged catheterization. We did intermittent clamping, and we have finally removed catheter after 2 weeks of illness, and we have discharged the child after 3 weeks of inpatient hospital stays. And the child is on now on follow-up, sir, under our pediatric and neurology department follow-up, sir.
Okay. So at discharge, was there any deficits? Was there any like areflexia and the motor deficits, the sensory deficits? How did they improve on at discharge?
Sir, at discharge, there is no motor deficit, sir, and sensory deficit also improved gradually, sir. But there is a prolonged bladder involvement only present in our case, sir. Nearly before discharge only, the child gained bladder sensation, sir. But there is no residual motor deficit and sensory involvement in this case, sir.
And bladder function is completely normal after you remove the catheter. There is no dribbling, there is no incontinence, there is no retention after removal of a catheter.
During the first after during second week of illness, we tried set catheterization, removing. The child developed retention and dribbling of urine was present, sir. Again we recatheterized, sir. Only after 2-3 weeks only child gained bladder sensation. After removing, there is no urinary retention and dribbling of urine, sir.
Yeah. So there is this important question of when there was so much of inflammatory markers, whether it's a COVID-related myelitis or it is a post-COVID. Are we right in saying that this is post-COVID? When you had a elevated CRP, D-dimer, all that markers, inflammatory markers were there. Whether it's a part of MSIC or whether it's a post-COVID or it's just a COVID myelitis.
Sir, the child had a contact history, sir. Contact history with the father.
But the inflammatory markers were so high. It's
Yes,
not only
sir.
just contact and antibodies, no?
Yes, sir. Inflammatory markers and COVID antibodies also reactive, sir. So it can be a post COVID sequelae MAC. I would like to consider, sir. Not,
Like when the syndrome was acute and there was still inflammatory markers, so it means it is COVID or any other infection for that matter. So you won't call that as post-COVID at that point.
Yes.
That is the question being asked.
Yes.
The echo was done.
Yes. Echo, yes, sir. Echo was done in this case, sir. It was normal, and we have started a low dose aspirin prophylaxis, sir, for 4 to 6 weeks, sir, and the child is on follow-up, sir. We have planned the echo on after 6 weeks. We have planned and review echo, sir.
So it can still be MSIC or it can still be COVID myelitis. So in there are in the literature there are many cases of COVID encephalitis, meningoencephalitis as well as COVID myelitis. All these are described in the literature. Not all the cases there were proof of isolation of virus from the CSF. Many cases CSF were PCR negative. In some cases even the PCR was negative, IgM antibody was positive. The RT-PCR nasal swab was negative, IgM was positive in some cases of COVID meningoencephalitis, but the CSF showed pleocytosis, but not the PCR positive. So many different categories of COVID myelitis or COVID encephalomyelitis or COVID meningoencephalitis are there. So it could be still COVID myelitis. Any other investigation? VEP did you do?
Sir, we have not done, sir, visual potential test.
That is one thing that is very important. And for subclinical involvement in the future course, for monitoring also VEP will be done because NMO is still a possibility with negative antibodies also. And it's a longitudinally extensive cord involvement. So optic neuritis can optic neuritis develop after
Yes, sir.
duration in case
Yes,
of NMO?
Yes, sir. It is possible, sir.
That is the most common presentation. Initially, there will be myelitis. After
Yes,
6
sir.
months, 12 months, 1 year, 2 year also, you can get optic neuritis
Yes, sir.
in NMO spectrum disorder. And NMO negative, NMO antibody negative again, it does not completely rule out NMO disorders. So you have to definitely follow the child with the MRI, with the clinical, and with ophthalmological examination, and looking for clinical, subclinical optic neuritis.
Yes, sir.
Any other investigations, any other things that you have done for this child?
No, sir.
Say, for example, if the child did not improve after 5 days of pulse methylprednisolone, what would you have done?
Sir, we have IVIG can be tried, sir. Can be second line of management in acute transverse myelitis, sir. IVIG or plasmapheresis can be considered in this case, sir.
Yeah, that's right. So plasmapheresis is one of the real options, and many cases, especially those cases with the prolonged shock and severe involvement, no improvement after 2 to 3 weeks, they have improved, shown very good improvement with plasmapheresis, with IVIG, even injection rituximab that is also used for second line immunomodulatory treatment for these severe cases. And the second course of IVIG and second course of IV methylprednisolone pulse also has been tried in some of the cases that did not improve with the first course. So all these different options are available for those cases that did not improve completely. Your patient has improved completely, so that's a very good end to the story. Any other questions from the panel, from the...
I missed the MRI because of your internet disconnection for a brief period. Can you tell what is the MRI finding?
Yes, sir. This is a T2 weighted image showing hyperintense lesion in cervical region and thoracic region, and this conus medullary region is also having a hyperintense lesion in T2 image, sir, and there is a cord enlargement is also present, sir.
Okay, thank you. Just brief period, it was not there, so I missed it. Thank you.
Yes, sir.
So if it was Guillain-Barre syndrome, how would you have managed this patient?
Sir, it is an acute medical emergency, sir. I would like to admit the patient, and first I have to do a rapid cardiopulmonary assessment to assess the airway, breathing, and circulation. And we have to closely monitor for the ascending weakness involving trunk, respiratory muscle weakness. We have to closely monitor. If there is any respiratory and muscle involvement, we have to intubate the child, and we have to provide respiratory support to the child, sir. And we have to take in consideration of general management, which include nutrition and pain management, physiotherapy, which has to be started on the day one of the illness. And we have to give a psychiatric counseling to the mother and the pediatric child. And we have to give DVT prophylaxis, and we have to prevent bed sore complication, and we have to give bladder catheterization care also, sir. And coming to definitive management, IVIG should be considered it has to be given in the dose of 2 gram per kg over 24 to 48 hours, or 0.4 gram per kg over 5 days has to be given, sir.
Which regime is better? Which regime is better?
Sir, 0.4
The 2 days
gram,
course or 5 days?
5 days. 5 days course will be better, sir, when compared to 2 days course.
In what terms? Like, why you say it's better?
Sir,
so in the literature, when it was compared, the 2 days regime versus 5 days regime, so the relapse rate, as well as the remission rate, as well as the later recurrence rate, all these were better in 5 days regime than 2 days regime. But in case of very rapidly, like this patient, rapidly progressive case, and there is a impending respiratory involvement, we do give IVIG over 2 days. But the 5 days regime is better in terms of the overall treatment effectiveness. Alternative treatments for Guillain-Barre syndrome, apart from IVIG?
Plasmapheresis can be tried, sir, 50 ml per kg on alternative days, 3 to 5 sessions to be given, sir. Steroids or second line, sir. No modulators are second line, sir.
Okay, fine. I think this case was very well presented, excellent presentation, and you have answered most of the questions very thoroughly, and you have prepared very well. You have done very good homework. Only comment I would like to make is, like, your presentation has been very extensively done, but I hope you will be able to do this in the examination setting in the long case, because you are allotted a very limited time there. All the very best for your examination, and all the other 2 students also.
Thank you, sir.
Hand over the mic to the other moderator as well as the panel.
Thank you, sir.
Thank you, sir. I think it's a very excellent, as Dr. Lakshminarayan said, yes, Dr. Kishore has presented a very excellent presentation. And Dr. Lakshminarayan sir has discussed very well this case. And Dr. Ramachandran sir has asked, do you see such a rapid and as well as almost complete recovery in transverse myelitis?
Yeah, so in Guillain-Barre syndrome and transverse myelitis, the recovery is nearly complete in most of the cases. That is one of the fortunate facts. Like recently, my senior colleague and HOD commented, like all these Guillain-Barre syndrome, the severe ones that we have seen, after 3 months, 6 months, they are nearly completely normal. Okay, even though the recovery took longer time also, it's nearly completely normal. So only thing the IVIG and the steroid does is it hastens recovery. It makes the hospital stay short. It reduces the complications due to the ventilator assisted ventilation and other things. But the natural course of these diseases is near complete recovery in most of the cases. Having said that, there are cases that have shown incomplete recovery, but the proportion is 10 to 20% that will show incomplete recovery or a prolonged deficits even after 1 to 2 years also. Fortunately, that is a minority. The majority, 70 to 80% of the population, natural history of the disease with or without treatment, they bode well and they show near complete recovery.
Even even before immunoglobulin and other things, we have seen rapid recovery, even adult patients when I was in this thing, and subsequently we have seen also. You are correct in that. Somehow these children are very lucky that even before immunoglobulin era, they were able to have complete recovery. Thank you.
Thank you, sir. Dr. Kishore, can you stop slide sharing?
Yes, sir.
Yeah, Dr. PRC, sir, any comment, please, sir? Yeah.
Thank you. This is a very good presentation, as already mentioned by Dr. Lakshminarayanan. Kishore had prepared very well, and he was very good and very confident at the same time as very composed when he was answering all the questions. All the very best, Dr. Kishore.
Thank you, sir.
I didn't have a chance to know your colleagues' names because you answered almost all the questions. So anyway, that's a plus point, obviously, for your team. And I congratulate Dr. Sendil. Thank you, sir, for excellently guiding his students and preparing, and also putting.
You see the proud face of Dr. Sendil.
Yes, thank you, sir. And of course, Dr. Lakshminarayanan was very, very nice and gentle. He actually, guided you very well. Nicely, the questions are asked in a, I'll say, very non-threatening manner, and it was really brought the best out of you. So we also have to learn as examiners how to ask questions. So very, very well done, Dr. Lakshminarayanan. So it's a thoroughly enjoyable session. Thank you so much.
Thank you, sir.
Thank you.
Yeah, Dr. Srinivasan, sir.
No, Ramachandran has already told whatever I had wanted to tell. I have already posted in the chat box. Excellent discussion and excellent answering by the candidate. Your presentation is very good. So a very bright future. All the best. And as Ramachandran correctly mentioned, you didn't have a chance for other two persons to answer.
Thank you, sir.
Okay, good. Of course, I know the way it has been discussed, the case thoroughly, each and every point has been analyzed very well, right from the history to the examination. Okay, by Lakshminarayan. So I know him. So he has been an excellent neurologist. And of course, congratulations to Dr. Sendil Kumar for mentoring and making the student do a very good job.
Thank you, sir.
Thank you, sir.
Dr. Sendil Kumar, your comment, please.
Thank you very much, sir, for your appreciation. All of them has appreciated him. Thank you very much for your kind appreciation, sir.
Yes, sir. Thank you. On behalf of IAP TNSC, I thank today's moderators, Dr. Sendil Kumar and Dr. Lakshminarayan, sir, and students. Kishore has excellent presentation. And thank you, our judges, Dr. PRC sir, Dr. Srinivasan sir, Dr. Elicit madam, and Dr. Janani, as well as Palasankar sir. And so I think that definitely the students will be benefited, and we are doing our best and for this COVID era to make our students get empower throughout. Even we are getting moderators from throughout India also. And so definitely will be a benefit to our students. Thank you, Ananda. Thank you.
Thank you, sir.
Thank you.
Thank you.